Okay,
Thanks.
great. So, welcome to our talk today. We are going to be covering treating pain in the community with an opioid stewardship focus. So the presenters are myself and Leland. So first, we'd like to acknowledge that we join you from Treaty 4 territory, the original lands of the Cree and Saulteaux peoples, and the homeland of the Métis Nation. We respect and honor the treaties that were made on all territories. We acknowledge the harms and mistakes of the past, and we are committed to moving forward in partnership with all Indigenous nations in the spirit of reconciliation and collaboration. I don't personally have any conflicts of interest to disclose. I am employed within the Saskatchewan Health Authority within the Department of Clinical Appropriateness and Stewardship, primarily in the Opioid Stewardship Program or Department. As you see here, there's the Sask Health Authority in the bottom corner. This work that we're doing is very much the work of the Sask Health Authority, and I believe there's an honorarium for this presentation. The other disclosure is that when I booked this talk, I was to have childcare, and my childcare provider is ill. And so if there's a little person that pops in, I very much apologize and ask for your grace, but hopefully that won't happen. So, Leland, do you have any conflicts of interest to disclose or anything to add?
I have no disclosures other than what's listed on the slide or been discussed.
Wonderful. Okay, so briefly, we are going to discuss acute and chronic pain, the introduction to the chronic pain pathway, introduction to opioid stewardship and using opioids responsibly, and methadone and buprenorphine prescribing guidelines. You are going to be treated to a very great talk on chronic pain this afternoon by Dr. Bolton. I've seen his slides, and so we did make an effort to ensure that you were receiving two different sets of information. Of course, there is some overlap in a couple of our slides about chronic pain, but we did try and spread that out a bit. So there will be pain in every single primary care practice in this province. 8 million people in Canada live with chronic pain, which works out to be 1 in 5 Canadians. Chronic pain is defined as pain that lasts longer than 3 months, and it disproportionately affects certain groups. So women, patients with a history of trauma, post-traumatic stress disorder diagnosis, patients who have substance use disorders or mental health conditions, primarily, PTSD, anxiety, and depression, members of the LGBTQ plus community, workers in the trades, patients who live in poverty or have disadvantaged socioeconomic status, Indigenous populations, and patients with disabilities. And so, everybody has, again, those populations in their practice as well. And so it would be very rare to find a primary care practice that doesn't have chronic pain in it. It's very difficult to fully alleviate or cure chronic pain. The goal is improvement in function, improvement in pain, and the improvement in quality of life. We do consider a 30 to 50% reduction in pain score of chronic pain a success, and it requires a multimodal approach. So it's really important to have these conversations with your chronic pain patients that every treatment that we try, it's not likely to fully take away your pain. If the expectation is that the pain will fully be gone, you'll be chasing that pain forever. Your prescriptions will be increased and increased and increased. And so kind of giving them those realistic expectations of chronic pain as a chronic condition is actually really helpful in helping them feel a bit more empowered in that self-management. And also just to lessen that anxiety a little bit as well. Of course, sometimes, if they go for surgery of their back, that can alleviate their chronic pain completely. But lots of times, certain conditions like fibromyalgia and things like that, it is a chronic condition. So acute pain. Is that just acute care's problem? No. So there are risk factors for poor postoperative pain outcomes. So we know that patients who have post-op pain, if their gender is female, if they had preoperative chronic pain, if they had preoperative opioid consumption, particularly high opioid consumption, if they had anxiety or helplessness regarding their pain, if they had a long length of surgery or younger age, they do have a poor pain risk for poor pain outcome. And when I say that, I refer to persistent postoperative pain, increased length of stay, and uncontrolled postoperative pain. So as you see patients and you know they're going to be going for surgery, and we'll talk about this later in the talk a little bit, but recognize which of your patients are likely to do well with their planned surgeries, especially if they're extensive or if they're orthopedic surgeries, and which maybe will have some challenges, and maybe take a few minutes to talk to them about anxiety regarding pain if they already have chronic pain. Because, of course, patients who have chronic pain, one of their hugest fears is my pain is going to be worse. My function is going to be worse. I'm going to be worse off than I am.
The Loxetine, how often do you take that?
Sorry, somebody's unmuted.
Okay. Yeah, and you just take the 30 milligrams?
Okay. Anyway, so, and also preoperative opioid consumption, if they're on high doses, there is a lot of evidence to say if you try and reduce that opioid amount prior to surgery with just even a small, slow taper, that their post-op outcomes for pain will be better. Okay, I'm going to hand it over to Leland here. He's going to start tackling some of the opioid stewardship talk, and then we'll come back again.
Good morning. I want to give I'm so excited to be here presenting. I see so many familiar faces and names. So hopefully we can spread, some good information and maybe change some ideas and get some progress forward. So Opioid Stewardship, it is a fairly new program within the Saskatchewan Health Authority. It is a provincial program. ISMP defines opioid stewardship as that coordinated intervention designed to improve, monitor, and evaluate the use of opioids in order to support and protect human health. We have an overdose, a fentanyl, a toxic drug supply crisis in this province, in this country, in North America. And opioid stewardship is a big part of that appropriate care and setting people up for success. So it is protecting that human health to reduce harms and provide good care. Next slide, please, Joe. So we are here to observe and learn in the stewardship role in acute care. We're here to support, and we're here to create guidance to inform committees and to inform leadership and providers and patients. This is not prescription review program. That there's a misconception that opioid stewardship is, at the hip of prescription review program. We are not. We are here really to work with the system, work with providers, work with patients, work with families to create understanding, to disseminate knowledge and implement changes for that best practice. So an example is I sit on the order set committee provincially, so we can provide evidence-based, we can provide information from the data we are collecting to inform better design of order sets or PPOs, because some of our PPOs are definitely not created with opioid stewardship in mind, because it was before this was implemented, and seem to preferentially go to using opioids for pain management rather than ensuring that the non-opioids are optimized and use opioids when we need to. So we're here to work with, not against, to create change through dissemination and implementation. And to remain relevant, we are part of doing with the team and learning and asking questions. Next slide, please. So choosing Wisely Canada, I'm going to base a lot of my conversation around the Opioid Wisely strategy through choosing Wisely Canada. Easy Google search gets you lots of evidence. This encourages thoughtful conversation between clinicians, patients, to reduce the harms associated with opioid prescribing. aims to share updated evidence where available. I'm aiming to share updated evidence where available. So a lot of these Opioid Wisely were created around 2018, 2019, and there's been some updated evidence. So I'm going to incorporate that today in some of the key Opioid Wisely statements and draw connections between the stewardship observation and common objectives across the care settings. Next slide, please. So as Jill kind of was setting up, is that this isn't an acute care, primary care thing. This is a continuum, and we're trying to start the conversation, share the information. So a big one is post-operative opioid analgesia, and working in primary care, in long-term care. This is something I saw all the time. And I felt I was doing best by continuing some of those opioids because we always want to improve that pain management. But I probably didn't put enough emphasis, and now I'm learning better, is to optimize the non-opioids where I can appropriately and use the opioids at the lowest dose for the shortest period possible. And this next slide, Jill, if you can advance there, please, is it is very key to use the opioids for the shortest time possible at the lowest dose. Because what the newest evidence is confirming is that after 3 days, so after that third day of opioid introduction, the rise in continued use and sequelae and complications from that opioid exponentially starts to grow. And the probability of extended use or problematic use exponentially starts to grow. So in primary care, or if somebody comes into a merge, part of that assessment is looking at the PIP. If they had surgery, were they dispensed opioids upon going home? And then asking them, are you taking them? How much have you taken? And are you using something other than the opioids for pain management, such as a duloxetine, a gabapentinoid, pregabalin or gabapentin? Are they on a Tylenol? Are they on an naproxen or a Celebrex? Why this is important is then you can assess, are they optimizing their non-opioid strategies to reduce these risks? Because the longer we go with the opioid in itself has side effects that can slow the healing process, but it also has the risk of continued use. Next slide, please. So combining opioids does not improve the post-operative recovery. So often, and I know I saw it in primary care, people will come out with a hydromorphone and a Tylenol 3 order. We see it lots in acute care, and that is because our order sets are outdated, and we're working to work with the group set B to optimize those order sets. But what the evidence shows us is for those minor or moderate surgeries, opioids were no more effective than just optimizing those non-opioids, which have significantly less risk if used appropriately. If an opioid is required, again, use it for that shortest period and lowest dose possible. Next slide, please. So this is a pictogram of what we mean by non-opioid analgesia. Some of it isn't possible in primary care, but much of it is. So starting at the top is acetaminophen and an NSAID. There is evidence now that NSAIDs are safe after orthopedic surgeries for up to 3 weeks. They do not stop that bone union. Randomized controlled trials, bringing many years of study together, it's a multifactorial piece that impedes bone union. So it's the additive effect: obesity, diabetes, smoking, alcohol intake. Opioids actually can slow bone union, as NSAIDs can also. So it's not one agent, it's looking at the whole picture. But even optimizing acetaminophen, meaning a minimum 650 to 1,000 milligrams scheduled, not PRN, scheduled. Take it around the clock for a period of up to 1 to 2 weeks, just to block that pain sensation at the surface at the site. No more than 4 grams per day, 3.5 to 4 grams. The randomized controlled trials are starting to come back, and the observation studies that maybe 4 grams is a little too much if we're going over kind of that 1 month period. So typically we're saying 3.5 to 4 grams there. Naproxen, celecoxib, Celebrex are kind of the two leading in the evidence for NSAIDs, and there is safety. There is things that need to be considered of how to make that as safe as possible. Gabapentin, pregabalin, the evidence has shown in that immediate post-op period, if those are introduced appropriately for those particular cases, neurological surgeries, back surgeries, and some orthopedic surgeries, if it was a long case or a difficult case, is that it can independently reduce the opioid utilization. Duloxetine, venlafaxine, so those are SNRIs. They, working in that norepinephrine pathway, have independently been shown to be able to reduce pain sensation and opioid utilization. So reducing that opioid demand in the postoperative period. In this role, something that, my fabulous partners in what I do and working with Jill, tizanidine was a muscle relaxant I didn't know about until I started in this role. Definitely some cautions to take is that it is a little bit more sedating and there is a slightly increased risk of falls, but in those big back surgeries, it works synergistically with the opioids in the alpha pathway to really change the pain perception. So it is an easy one for a short period of time. If somebody is, in really excruciating pain, can really make a big difference if the baclofen or something else isn't working. Then we have some more of the interventions, the lidocaine, the ketamine, the regional anesthesia. Of course, that is within the acute care setting. But it's just good to be aware of some of those different options. Next slide, please. Opioids for long-term chronic pain. This is something that this afternoon Tim is going to cover in detail, and a lot of these concepts it's using that multimodal therapy, using the physical therapies, the mind-body therapies, cognitive behavioral therapy. Medications are just a piece of it. So there's lots of evidence out there through the College of Physicians and Surgeons about chronic pain, and then through CEP in Ontario, their academic detailing. So there's going to be lots of conversation on this in the afternoon, so I'm not going to spend a lot of time on this here. So Jill, I think you're up next. You're muted, Jill, if you're talking.
I am, in fact, talking. Okay, so now we've given you all of this information on, kind of what not to do and what to consider. And so you might be thinking, okay, so what am I supposed to be doing here? And often we see this a lot in the hospital, we'll see patients who have, 600 morphine milliequivalents per day for their chronic pain. And often it'll be, the providers have inherited those patients and they've just been trying to navigate that. And so there are tools that exist for, when you get these chronic pain patients, how exactly you handle them, whether it's new chronic pain or whether it's long-standing chronic pain that you've inherited in your practice. So this is the Saskatchewan Health Authority chronic pain pathway. It is a Regina pilot. They started in the Regina area to just try and get something off the ground. I believe they are working on a provincial chronic pain pathway as well, and it launched in 2022. So I apologize if you are familiar with this, but I know there are lots of people who aren't familiar with this. And so I just wanted to introduce you to it briefly. So the chronic pain pathway, it does focus on 4 different areas. So prevention through physical activity, nutrition, smoking cessation, and sleep quality. Assessment, so how to actually fully assess chronic pain in your practice. The risk factors, so what are the red flags that you need to have further investigated or addressed? And what are the poor outcomes risks? Just sometimes being aware of multifactorial reasons that patients can have uncontrolled chronic pain is really helpful. And then management, so that multimodal. So the next so this is a QR code. Hopefully it works for all of you. I very much invite you to log in with your phones or your devices at this point, because I'm going to be showing you the chronic pain pathway instead of putting it on slides where nobody could see it. Let's see if my hyperlink works. It did. Yay. Can everybody see that?
Yeah, I think
Yes.
it opened on a different screen. We can't see the.
Oh, yeah.
PDF.
Let me share that screen. Technology. You share and this one. Okay, everybody should be seeing this here. Okay, can everybody see that?
Yeah, it's there, Jill.
Okay, so of course there's that QR code that I generated for the purpose of this presentation. However, if you just Google like SHA chronic pain pathway, you'll come to this page. And so this is the chronic pain pathway. There's a couple of different things here. This is the chronic pain pathway. This is patient information in here. But if you go down, you'll see the chronic pain pathway provider information. So if you click into that, it'll also give you a couple of different things. So if anybody is quite keen to know more about the chronic pain pathway and how to use it, Dr. Liskowicz and Dr. Bolton did do in November 2021 a full presentation on that. There's a EMR work standard in here. If you have a data analyst that can put that into your EMR templating. And yeah, that's kind of there if you guys want to see. However, I will show you the chronic pain pathway. So this is the chronic pain pathway. Large amounts of work. I cannot take credit for any of this work, but it was in part of the clinical appropriateness department who did did some work to this. I know the chronic pain clinic and some physiotherapists across. It was a multifactorial effort to get this off the ground. So certainly I can't take any credit for it, but I am happy to show it to you. It was last revised September 21st, 2023. So it should be fairly up to date. So this is what, and it's about a 7-page document. And so if we go through, the first category, of course, is that prevention that we just talked about. So there's lots of tools in here. So there's, if you want to give chronic pain and exercise facts, lots of times people with chronic pain are quite scared of exercising. They don't want to flare their chronic pain or make things worse. If they are in Regina, there's the Paul Schwann Center, smoking cessation. So we know that smoking does worsen or contribute sometimes to that worsening inflammation. And if they're certainly going for surgery, that risk of malunion of their surgical sites. Nutrition, we know that chronic pain does disproportionately affect people of low socioeconomic status. So things like the food bank and how to access that, and sleep quality. And then if you move down, this is kind of more the medicine part of it. So, review those records, look at the PIP, look at what's been done, look at their surgical history. What are their goals and their priorities? Are they expecting to be 100% pain-free? That requires a focused conversation. A focused pain history. So, how do we actually do this? So PQRST or old CARTS is something we're all very familiar with. But this actually has, evidence-based brief pain inventory is an excellent tool for how you take a pain history. And then the physical exam. So, to do a full physical exam on that. Because the thing about chronic pain, and I just want to caution everybody, is that while we often can't cure chronic pain, we also shouldn't be just throwing our hands up and saying, oh, they have chronic pain. It's never going to get any better. I never need to readdress this. Certainly things can shift. Certainly people's pain or the conditions that cause their pain can shift. And so sometimes it's, you have chronic back pain, but maybe you've re-injured it and now you do have, a disc that's out that is pressing on a nerve. And so just always to revisit that. Is there anything new about it? Is there anything that needs adjustment in this chronic condition, similar to how you would do that with any other chronic condition? And then pain interference. So things that can be making things, worse. Screening for neuropathic pain if indicated, and for primary pain as well. So there's headaches in here, fibromyalgia criteria, just a lot of that diagnostic criteria is in here. And it's all hyperlinked. So if you have a new patient in here who says, I think I have fibromyalgia, you can just pull up the diagnostic criteria of that throughout the pain pathway. Red flags, of course, and I won't go into this too terribly much because I know Dr. Bolton is going through red flags in his presentation. But again, we talked a lot about poor outcome risk factors. So that PTSD component, depression, anxiety, all of this screening is in here. And I will tell you that it is something that we ask in our work in acute care for our pain patients. We ask about depression and anxiety about 100% of the time, because often there are medications out there that will treat both concurrently, or if they're on a citalopram, for example, there's other options that are better that can treat both pain and anxiety and depression. And so it's always really important to be screening so that you have the least amount of medications for the best amount of effect with your chronic pain patients. And then management. And if you look here, you can go through this kind of on your own time. But different SHA physiotherapy service locations, if you think that they are a candidate for WASCATA, that's in here as well. Clinician resources, patient information resources, and then when to refer, how to refer. In here, SHA mental health support, mobile crisis services. There's just a pile of hyperlinked resources in here. So it's kind of a one-stop shop for chronic pain management. And then it'll go through the guidelines, so pharmacological management of neuropathic pain. Again, Dr. Bolton will be going through that this afternoon. Non-opioid medication, so what we've just really extensively talked about. There's a beautiful little chart that lays that out. And then, sometimes, like I've just said, that pain does require further investigation, or it does require further services. So interventional pain medicine, would they benefit from, a nerve ablation or an injection of some sort? Is this something that requires, complex pelvic pain? There are specialists that deal with that. Do they have a component of addiction in their chronic pain? And so do you need to refer them on for further treatment of that? Psychiatry, physiatry, and rheumatology. And so again, and then here it kind of gives you a bit more information about pain in general. And then the guidelines. So when you would refer for interventional pain medicine, when you would refer to OBGYN, when you would refer to addiction. So if you go through this, it's all in here as well. And so this is something, we can come to these talks and we can say, this is best evidence. This is what you should be doing. But is that helpful to you in real time? Because chronic pain, it is very time consuming to treat, and it is a chronic condition. And so this is just a fantastic resource that I invite all of you to become familiar with, to help you with implementing some of these recommendations that we're making today. So yeah, that's that. Okay, I'm going to get back to my presentation here. Go all the way. Sorry, guys. Okay. Leland, take it away.
You bet. So everybody learns differently. So we've incorporated some cases. Just go back one slide. She gave it away on me here.
I'm sorry.
So if people are paying attention. So everybody learns differently. I know I learned from cases. So I've selected a couple cases just to kind of demonstrate what we're talking, what we're trying to share, and help build that thinking in community across the continuum of what might be going on, and what kind of assessments and things may I need to be thinking about. So this case was one we actually did see. 52-year-old female. We were consulted postoperative day 1, extensive spinal fusion surgery. So a long surgery, a complex surgery. Opioid pain consultation service was contacted to review as the unit was unable to control postoperative pain with hydromorphone 4 milligrams IV Q3 hours. And she had a PCA. So there was lots of opioids going in. She had limited oral intake, extreme pain with any movement in bed. The key piece, and I'm going to highlight this, is the sheets moving on her legs hurt. The air circulating in the room hurt. So those are key statements in kind of what are those initial thoughts. And so this is something I did come across in my time in continuing care. So I was familiar with it. But that is a key statement, is when the air hurts. Next slide, please, Jill. When the air hurts, when the sheets hurt, that should be a red flag for any clinician that something else might be going on here. So you can put in the chat if anything's coming to mind. We can get the conversation going that way. So the setup is the chronic pain had been there, the back pain had been there for 20 plus years. This patient had already had 2 prior back surgeries. So there's scar tissue. This was complex. This was an extensive surgery. Her function at home, she worked remotely from home while laying in bed the bulk of the time. She had limited upright ambulation to being forced to crawl around the house because she wasn't able to walk. So if we talk about pain and then we look at function and we're treating, the function wasn't very good here. And the pain was extensive prior to the surgery. So she describes her current opioids as managing her pain, and she couldn't have lived without them. If you can put in the chat, is there an opioid that you think she may be on and why? And this is a conversation. We have seen this and the evidence confirms it. Next slide, please, Jill. So what she was on at home was oxycodone. And why that's significant is oxycodone does seem to have different actions as an opioid and typically does not respond over time the same way as the other full mu opioid agonists. And she was on significant oxycodone. She had a sustained release, 100 milligrams twice daily, plus she was taking 40 milligrams TID PRN. And she was taking the PRN as schedule, not as PRN. So she was on a morphine equivalent of 660 milligrams plus in that calculation. And over the last 10 years, there had been an incremental and steady increase in her opioid dosing with function decreasing. So why is this significant? And then when we go back to the air and the sheets were hurting her. So next slide, please, Joe. What we were seeing clinically was, next slide, sorry. What we were seeing was an opioid-induced hyperalgesia. So the opioid, as they introduced hydromorphone to try and treat the pain, her pain actually got worse. So it's a nociceptive sensitization at the nerve in the spine and in the brain. So we also refer to it as a centralized pain. So the opioids were now doing the opposite of what we would suspect. And I have seen this in continuing care, high dose opioids, and all of a sudden they're doing the opposite of what we would expect, and the pain is actually escalating along with a functional decline. Also with this was opioid tolerance, and the increased dosing, that incremental increase, was causing an increase in the pain. Next slide, please. So opioid-induced hyperalgesia must be considered a pain crisis, and it needs urgent attention. In primary care, your number one first-line step would be a dose reduction of the current opioids, and you're likely going to see an improvement in the pain. So you do a controlled reduction. The easiest way of doing that to decrease the morphine equivalent, and I know Tim will go into detail, Dr. Bolton will go into detail this afternoon on opioid morphine equivalent and rotation. But the easiest way is to do a rotation to a different opioid. Because when you do an opioid rotation, you automatically do a 30% reduction, 30 to 50% reduction in that morphine equivalent to account for cross tolerance between opioids. And so that first step that can be done in primary care can have a significant impact in reducing pain and improving function. The second line options are we need to work within that NMDA receptor pathway, so ketamine infusion, something in acute care, or rotation to methadone is a different option. And if you're not a methadone prescriber, then it's reaching out and working with somebody that is, but being able to identify the opioid-induced hyperalgesia is key. Next slide, please. So we're going to continue with some of the Opioid Wisely, Orthopedics Canada and the Rheumatology Canada for osteoarthritis is really for arthritis. We want to make sure we optimize those non-opioid approaches first and not minimize them. This can be a difficult population, often older adults with chronic renal disease. Different medications can have different impact on function, but as long as you're trying and documenting or documenting your rationale, then you can make the case for whatever treatment pathway you're taking. It's just to think about those different options. Next slide, please. Codeine. This is something that my personal opinion, which doesn't matter, is I think we should be taking the steps like some other provinces like Manitoba have and have removed codeine. It is fairly restricted. Okay, so there's a comment there. Jill, I'll just have you take a look at the comments as they come up while I'm talking, and maybe we can address them when in the presentation. But codeine is processed very differently in different people. If you're taking a Tylenol 3, the analgesic is likely coming from the acetaminophen, not the codeine. The codeine is great at causing disorientation and constipation. So I think just keep that in mind. The codeine isn't doing much for the pain as what we often think. Next slide, please. Back pain. So I'm going to go actually right to the study, because pretty much all the Opioid Wisely is, optimize your non-opioids. So this study is actually very recent. It was in the Lancet 2023. The key is when they did a side-by-side opioid to using placebo, at no point in time did the opioid group have a greater pain relief. And this was at 6 weeks, and they followed them for a year, up to 52 weeks. The opioids never once did they work better than a placebo treatment. So this is just a key piece of information to keep in mind that, try the non-opioid first. It's often the movement that's going to have the most benefit. And these individuals could have radicular symptoms, but no alarm symptoms. So it wasn't simply just the run-of-the-mill stiffness lower back pain. they could have radicular symptoms. And so this was a very interesting study that gives us some of that longitudinal information to make decisions on. Next slide, please. And then perioperative buprenorphine. So we're going to go into a little more detail about buprenorphine. Suboxone is, the brand name of buprenorphine naloxone, but buprenorphine on its own is an opioid. And if somebody is going in for surgery that you're within their circle of care, maybe their primary provider, is special consideration with buprenorphine, or somebody comes into presents to emerge, and you're the RN, buprenorphine is a good analgesic. And we're starting to kind of see a change in the evidence of what we need to do with this. And we also need to understand if somebody's on buprenorphine, whether for chronic pain or for opioid use disorder or polysubstance use disorder, is that we are going to have to change our approach of how we treat an acute pain a little bit. But it is possible. But the evidence does show us that next slide, please, if we discontinue the buprenorphine or reduce the dose of buprenorphine with acute pain or with going into surgery, the dangers and the risks outweigh any benefit we thought that may have had. So it destabilizes, they can return to use, unintentional overdoses because they've lost tolerance, and increased patient anxiety, decreased trust, and decrease in that therapeutic alliance. And I would say most often, in my observation, is that continuation of trauma and trauma experiences. And if with a dose reduction, there's always concerns with conversions and restarting, and there can be errors. So the evidence is pretty clear that we should leave the buprenorphine as it is, if we can, in most cases, and just utilize other strategies to treat an acute pain and that postoperative pain. Next slide, please. So in Saskatchewan, you may be noticing an increase in the buprenorphine, Suboxone, but the buprenorphine products that may be out there. And we reach out to the drug plan, and it definitely is true. So this is just a bit of a heat map from north to south. So each of the dots is just those horizontal zones. So the south is it's between 0 and 6 per 100,000. Regina and the north zones are the largest at about 30 per 1,000 people are on a buprenorphine product. Saskatoon is closely behind, 19 to 24 per 1,000. So, and it is climbing year over year. We're seeing the utilization of buprenorphine increasing. For opioid use disorder, it is the preferred because it has some very significant safety components with it, protecting against overdose if people continue to use while on treatment for opioid use disorder. And it does not have the euphoria piece that other opioids have, such as methadone, which is also used for opioid agonist therapy and opioid use disorder treatment. Next slide, please. So the basic pharmacology, this is from Veterans Affairs. This is one of the best pictograms I've been able to find. It is a mu receptor agonist. The literature says partial. I think there's some debate about that. It definitely gets into the pain receptors, but it more acts in the spinal and the peripheral nervous system rather than attaching in the brain and causing a bunch of CNS side effects. So it has some significant benefits when you compare it to other opioids, such as hydromorphone, morphine, oxycodone. Decreased risk of constipation. It does not reduce doesn't impact immune system as much, causing that immune suppression, such as other opioids. Young adults that have chronic pain, if they require opioids, it does not contribute to hypogonadism. and depression, suicidal ideation. There are actually right now independent studies occurring in the United States and Europe utilizing buprenorphine for resistant depression, major depressive disorder. So those aren't out yet, but it is happening because with the utilization of buprenorphine, we're seeing different benefits. The kappa opioid antagonism, again, it's that decreased depression. I know in my primary practice, I would see that all the time. People on long-term opioids, and just their whole personality changes over time. And so if we can reduce that and have some benefit if we need long-term opioids, it's definitely something to consider. Next slide. So who this could be considered in for long-term chronic opioid utilization? Poor unpredictable gastrointestinal absorption because you have the sublingual option, so we can bypass the GI tract. Difficulty swallowing, older adults because it does not it doesn't have the CNS depression, and it's does not have the metabolites and isn't as dependent on the renal filtering. We need to exercise some caution if severe hepatic impairment. If you're seeing rapid tolerance developing with any of the other opioids, maybe start considering buprenorphine. Those patients with hepatitis C, HIV, multiple sclerosis, any of those immuno-related and pain, then this could be something to consider. And those younger patients and any patient that wants to remain sexually active and don't want the impacts of hypogonadism. Next slide, please. So the biggest thing to understand is buprenorphine has that very strong magnet into the pain receptor. So why this is important is if they're on buprenorphine for any of the approved reasons why, is that instead of reducing the dose or trying to treat an acute pain, know that hydromorphone is next. So the lower the number, the stronger that magnet is into the receptor. Hydromorphone is next on the list. So hydromorphone can get in and find those receptors that are empty. You just may have to give a bit higher dose than you would typically give to get into those receptors. Next slide. As we talked about before, the toxic drug supply in this province, it's very clearly demonstrated that here, I would draw the line that buprenorphine demonstrates its safety here, and that buprenorphine blocks fentanyl and a lot of those other opioids because of its high affinity, reducing the risk of overdose. Methadone, I equate methadone like the warfarin of opioids. It's very weakly bound, just like warfarin is. Tylenol knocks warfarin off, and then we have INRs that are high. Methadone is weakly bound. It's at the bottom of that affinity list. So other opioids can find the receptors and get in, and we can have a multi-opioid overdose. So buprenorphine definitely has some advantages in creating safety for the population and population health. Next slide. So our different formulations, the subdermal implants have been off the market. So we have Suboxone, film, and tablets. Unfortunately, right now the film is not covered by the Saskatchewan formulary, but it is covered by NIHB. We also have subcutaneous injection, Sublocade, right now only indicated for opioid use disorder, but there is some practice and evidence where it has been utilized in chronic pain, but is not an approved use. And then we have the transdermal patch. Butrans is for pain management only, but again, is not covered. So it is out of pocket, which is unfortunate. And we are doing some advocacy with the formulary on these pieces. Next slide. So just a bit of a myth buster. People, Suboxone has naloxone in the tablet. You take it sublingually underneath the tongue. It is not the naloxone. If anybody has seen a precipitated withdrawal with buprenorphine or Suboxone, it is not the naloxone that's caused that precipitated withdrawal. It is the buprenorphine. What happens is if somebody's not in withdrawal and they have a use disorder, or they have a tolerance to opioids because they've been on long-term opioids, and we give them Suboxone, because of that high affinity, that strong attachment, the buprenorphine actually pushes very rapidly all of the opioid off the receptors, but doesn't get enough into the receptors to prevent a withdrawal. So that's what causes it, is actually the buprenorphine, not the naloxone. So that's why it's important to know how to initiate that. Important to administer under the tongue, let it absorb, 10 minutes for absorption, no eating, drinking, talking while that absorption is there. Next slide. So once daily, typically for the film or the tablet. For pain management, it works very well for analgesia chronic pain, but you need to divide the dose 2, 3, or 4 times a day, plus minus a PRN for that. Next slide. Butrans patch is every 7 days. Sublocade is a once a month injection, and this is really changing the use disorder treatment landscape in that offering that ability for once a month. Just have another case here just to demonstrate how Suboxone can work for pain management. Left abdominal stabbing, non-surgical spleen laceration, perforation of the diaphragm. Hydromorphone was not managing the pain, and oral was being tolerated, so they could have oral. Next slide. So background polysubstance use disorder, they were on Suboxone, 24 milligrams once daily for the opioid use disorder, polysubstance use disorder. They had no dose for 36 hours. So weren't in Suboxone hangs, buprenorphine hangs around for a long time, but the analgesia wears off fairly quickly, 6 to 8 hours. They weren't in withdrawal. They had some mild withdrawal, tremor, sweats, and cravings, but they were still doing okay. They had only had 1 dose of PRN, and there was a no NSAID order. So now what? Next slide. So let's use the Suboxone. It's what they're already on. It's what they're used to. So we gave a 6 milligram immediately and then split dose 6 milligram. So didn't really increase their daily dose and gave them a PRN. So following up the next day, they and then gave the acetaminophen QID to help with those muscle aches and pains, and gave options for withdrawal symptom management. But once we gave that Suboxone 6 milligram, next slide, then the withdrawals actually went away. The pain was much better. Next slide, please, Joe. The next day, the pain was much improved, and with the every 6 hours of the Suboxone, no further pain modalities were required. And I think it's you, Joe.
Okay, we're just going to quickly wrap up here. And so, yeah, I just wanted to also put into that, you know, when we're looking at opioid use disorder and buprenorphine, the max is about 24 milligrams. With chronic pain management, you can actually go up to 32 milligrams. There's lots of, I don't know, and not really clinical trials, but lots of different explorations of buprenorphine happening across North America. And so, you know, there's lots of studies going on with higher doses and different ways to dose things. But typically that's what you'll mostly see. Okay, so there was a question that came through about, you know, what if you're not a methadone prescriber? And so I wanted to just quickly touch on that. And the reason for that is I will tell you that a very, very large amount of people that we are consulted for in the hospital have a concurrent opioid use disorder. And there's reasons that is such a large portion of our population. They just don't experience pain in the same way that patients without opioid use disorders do. There's receptor changes and physiological changes for that. And so we often will, you know, if we have an opioid use disorder patient that has surgery, of course, we still use opioids post-operatively. But if they're interested in recovery, then we do try our best to start opioid agonist therapy, or at least get that process started. And so then that kind of falls into the addiction world of things. But Occasionally we will, especially if we require an opioid rotation on patients. So, the 600 morphine milliequivalents for 20 years, lots of times we end up rotating. And sometimes we'll rotate to methadone, sometimes we'll rotate to Suboxone, and that is primarily for pain, not opioid use disorder. And so those patients will come back to you in the community. The other thing I do want to say is that the chronic pain clinic is an excellent place, and what an asset in this province. However, the chronic pain clinic, I believe Dr. Bolton will touch on this as well, does not keep patients forever. It is a program designed for patients to move through. And so sometimes patients will be rotated to methadone or buprenorphine in that clinic setting, and then they will come back to you in your practice to continue that treatment plan. And so I do want to, and there's a lot of concern, understandably, from the primary care world about what that means. There was a lot, I often joke that there's tons of restrictions for buprenorphine, but no restrictions for oxycodone, right? And so on May 19th, 2018, Health Canada removed the requirement for physicians to obtain an exemption to prescribe methadone of Controlled Drugs and Substances Act. Pursuant to regulatory bylaw, the physician is not required to obtain approval from the register to prescribe buprenorphine either in its transdermal form, nor is it a physician required to obtain approval from the register to prescribe buprenorphine or methadone solely for the purpose of pain control. So if it is a patient that does not have a concurrent opioid use disorder, then you can go ahead and continue the methadone or the buprenorphine. This is the CPSS guideline. That being said, methadone in particular is a risky drug. It is. It definitely has its place. But I mean, I've seen patients come in to emerge with inappropriate adjustments, right? So methadone, you want to adjust this extremely slow by just a milligram or two. It's about every 8 hours that you use it for pain. And so you can't take somebody who's on, say, 5 milligrams 3 times a day and put them on 5 milligrams 4 times a day. Their risk of overdose and falls is high with even just a small dose adjustment like that. So I do always strongly recommend doing extra education around the methadone prescribing, even though there is no need to submit to the registrar for that, for physicians. I see there's a question in the chat. Macrodosing. Okay, yeah, we'll come back to that, Julie. Okay, and then the CRNS for the NPs in the room here, there's 2 different streams. So applying for buprenorphine for pain management. When you're a nurse practitioner, there's no additional education requirement or registrar approval to prescribe buprenorphine in any form or buprenorphine solely for the purpose of pain control. So you can prescribe Butrans patches, you can prescribe Suboxone. If you get a patient back from the chronic pain clinic on one of these, you can continue it. Applying for methadone for pain management, there is still a requirement of approval and education. There's a methadone for pain and palliative care course, and a 1-day internship with improved methadone initiating prescriber is required. So this is something that the Clinical Appropriateness and Stewardship Department can certainly help you with. Further in the slides, there's our email. This is something that we can help set you up with a prescriber for to get done. Even for the physicians in the group, if this is something that you know you can do, but you're not comfortable with and you'd like some more hands-on experience with this, certainly please reach out to our program. We're happy to take you in and help you to become one of these prescribers. This is going to become more and more pressing as we try to work ourselves out of the opioid crisis that started several years ago. And so I'm just going to leave this up. This is the Opioid Stewardship email. So if you email that, it'll go to our department and then we can help sort out any questions or help people with mentorship opportunities. Okay, I'm looking through the chat first to see if there's any questions in here. So Julie Yee has asked, do you see any macrodosing of Suboxone in hospital before discharge? So Leland has actually answered this, but I'll speak to it as well. The macrodosing is much more common for primary opioid use disorder. So RAM in the addiction medicine clinics will do that. In our world, lots of times our patients are post-operative or trauma, so they've already been given opioids. And so if we macrodose them, of course, with the Suboxone, we would put them into precipitated withdrawal in the hospital. And so our approach is typically a microdosing approach over 7 to 10 days, where you just give tiny little bits of Suboxone every day as it slowly replaces the receptors with the Suboxone, so they don't get that big precipitated withdrawal. That's typically our approach when it comes to switching over for pain. And then Carissa wanted to clarify, primary care providers can prescribe methadone and buprenorphine for pain without extra training and not for opioid use disorder. Correct. So if it is just for pain management, there's no opioid use disorder component, you can, unless you're a nurse practitioner and it's methadone, then you do need to do extra training. As soon as it's opioid use disorder, you do require both the CPSS and the CRNS requires additional education training, which that training is free, as well as approval from the registrar and lots of times some mentorship. Okay, and so for support, can we contact the chronic pain clinic pathway phone number? Leland, maybe I'm on maternity leave, so maybe Leland can speak to this, but my understanding is the Opioid Stewardship Department is probably your best bet to kind of get that mentorship.
The chronic pain clinic is in the pathway that is for the assistance with your prescribing. So if you have a case, you might have that's a consultation service. So that's kind of a consult, get some tips, and then they hand them back. But there is a patient assessment. If you have quick questions or things like that, you can send Opioid Stewardship an email or give us a call, because we might be able to coach through some of those cases and just optimization and things like that. If you're looking more on the regulation side, then it's a reach out to CPSS or the College of Registered Nurses. If you need clarity about what can you do within your license. I think the biggest thing we're trying to pass forward is with what we have going on in this province, this likely is not something you're going to be able to avoid no matter what part of the province you're in. You're going to be seeing this, and we're just trying to build that confidence and that comfort and consider getting your regulatory approval for methadone and buprenorphine for opioid use disorder, because there is a lot of crossover. It's the triad: chronic pain, mental health, and use disorder.
Yeah. And to clarify, the Opioid Stewardship Department, I think Leland did have a slide on that, but it is nurse practitioners. There's a physician that works with us part-time as well, and then a couple of pharmacists for clinician staff. And so there are people there that can give you a hand if you have any questions or need some mentorship. Are there any other questions?
Don't be shy. I think we learn best through conversation.
Okay.
So there's a question about Saskatoon. So it'll be a hub and spoke model. There is a spoke clinic being set up as we speak. So there will be a stabilization in that chronic pain service within Saskatoon within the coming weeks to months.
Although I would clarify, there are a couple of options in Saskatoon currently. It's not the big interdisciplinary team that they have in Regina that you'll learn lots about this afternoon. So there is the U of S has that medication assessment and chronic pain medication clinic, but interventional pain medicine, there is a new Saskatoon clinic called the Saskatoon Interventional Pain Center. So this is there's 2 physicians there. And so it is, they provide medical management and advanced image guided procedures there. This is a fairly new clinic within the last couple of months. The director was a physician at the chronic pain clinic in Regina and is now relocated to Saskatoon. So there's 2 physicians there. The consult form is online as well. So that is the Saskatoon Interventional Pain Center. But they're not quite the full encompassing model that Regina is, to my understanding. But there's some work going on with that as well, province-wide.
And I had a great question. It was a direct message, but I think it's for everybody, is if I have somebody with opioid use disorder, who do I refer to? So many of the health authorities have centralized opioid use disorder therapy clinics set up. They may be under different names, but like in the Southwest, there's one in Swift Current, there's one in Moose Jaw, there's one in Regina, one in Saskatoon, Kamsack, Weyburn, and Estevan both have clinics. So it's just look into what, there might not be an official name or clinic, but there's usually prescribers and providers that can assist with that service. But that goes back to the original message. If some of us can start to take some of that burden away and start maintaining these people with opioid use disorder in our practices, then those central clinics can assist more people. The one in Regina is completely overburdened because they cannot hand people off for maintenance.
Okay, do you know of any resources further north or any plans to bolster services in the north? That I'm not aware of anything, kind of PA or north is maybe what you're wondering about. Leland, are you familiar with anything?
I think a lot of that is why the opioid and substance use support line has been set up. That is a provincial service offered through the Regina OAT Clinic. It's a call service. You can access the SHA switchboard. It's a clinician to clinician, and they may be able to help if somebody does not have access or the ability to access an opioid use disorder clinic. Then there is the option to reach out to the opioid substance use support line. So OSIS is the acronym, and the easiest way is just call switchboard, and they will forward it to the physician on call. But it is a clinician to clinician, so it has to be prescriber to prescriber.
Okay, well, I guess I'll have to interject some really good questions. Q&A happening here, and I don't mind my talk being cut off for this good discussion, but I just want to thank Jill and Leland very much for sharing their expertise today, and congratulate you on the great work that you are doing for people who live with pain in our province, and particularly to keep them safe and looking at effective treatments at the same time to manage their pain. So thank you so much for taking the time today, and I'm happy to facilitate any further questions by the end of the day to pass them on your way if that's okay, and we'll go from there. So thank you so much again, and I will share my